My name is Tim Edmisten. I'm a native of Boone, and I was blessed with the opportunity after I graduated from high school here to perform 14 years of education and training at UNC, East Carolina, and then ultimately to do general surgery training in Roanoke and Charlottesville, Virginia. And subsequently, I was able to train in specialty training in surgery of the chest. We call that general thoracic surgery in London, England. Because I was a native of Boone, I knew I would be coming back to this area. And at that time, we had a thoracic trained surgeon who was soon to retire in 2000. And I wanted to have the opportunity to continue to provide the care to the people of this region and also to be able to build the thoracic surgical expertise. And it's been really exciting to see how that's evolved over the last 25 years. We went from the traditional 8-inch incision to remove a lung cancer, which is a painful operation called a thoracotomy. As you can imagine, it takes quite a while to recover from that and be able to return back to activities of daily life, including getting back to work. But in 2007, we introduced VATS, minimally invasive surgery. So we were now taking out half the lung through a less than 2-inch incision using a video camera. Patients had less pain, less complications, and quicker return to work. We also, within the last decade, introduced other technologies, minimally invasive technologies that allow us to go into the airway with a light called bronchoscopy, and you could only see areas in the airway that were accessible. But now we have advanced technologies, one of which is called endobronchial ultrasound, or EBUS. And this technology uses an ultrasound probe on the end of a scope so that a patient is placed under anesthesia. There are no incisions required. We're able to advance a light down through the breathing tube. And with ultrasound technology, we can see masses or lymph nodes on the other side of the airway. In the last couple of years, we also developed an even more specialized technology called navigational bronchoscopy. And the best way to describe this technology is it's similar to the GPS in your car. So when you drive down the street, it tells you whether to turn right or left. Well, as you can imagine, when we navigate into the airway, it's a very complex system of airways. Navigation allows us to use the information obtained from x-rays, which gets synchronized with a computer and the patient's anatomy that we see when we go into the airway with a light. And we can actually, using this minimally invasive technology, direct biopsy instruments out into the edges of the lung, an area that we would have never been able to access before without a much more invasive procedure. And in most cases, 90% of the time, we can get a biopsy that gives us a diagnosis and tells us if the mass is cancer or not. And then it goes another step. This past year, our hospital has purchased the latest rendition of the Da Vinci 5 robot. And so both the general surgeons and myself in thoracic surgery are now using this technology to provide minimally invasive surgery for our patients. And so what the robot does is it allows us to have much better visualization of the structures that we're operating on. It also allows better articulation of the instruments, more so than what we could do with our hands, and access to areas that we might not have been able to access before. And as a result of that, our patients are having bigger operations done less invasively, which leads to less complication and quicker return to productive, active lifestyle.